You are listening to the podcast That's Life in Sweden, or as we say in Swedish, Sånt är livet i Sverige, with me, your host, Lisa Uusimäki. Based on current research, there are no alternatives to chemotherapy, radiotherapy, hormonal therapy, or targeted therapies for the treatment of breast cancer. Today I'm speaking with oncologist Karolina Larsson from Sahlgrenska University Hospital here in Gothenburg, Sweden, about breast cancer treatment and especially about her take on alternative treatments. Welcome to the podcast, Karolina.
Thanks a lot.
How are you?
Well, I'm fine. I'm great.
And you're especially great because you watched the football.
Oh, yes, I did watch Sweden playing their first game in the World Cup now and beating Tunisia with 5-1.
Wow,
So
5-1.
great.
There you go. Okay, interesting. Now, if you're interested in football, so there you are, you heard it first here on the podcast. Karolina, talk about who is Karolina Larsson and why you chose to study medicine, especially specializing in oncology and breast cancer.
Oh, yes, that's a great question. I mean, I've been a doctor now for many years. So when you ask me these questions, I kind of needed to track back and try to figure what I was thinking when I started med school, which is now 20 years ago. But I really believe that it was the combination of pathophysiology and I wouldn't say psychology, but rather meeting people or patients who are in a vulnerable situation that fascinated me. At first, I did want to become a psychologist, and I was accepted to that education as well, but I decided to change. And then before I could start med school, I needed to do 1 year to study maths, physics, chemistry, and biology, since I didn't study those things in high school. So I came kind of from that angle, I would say.
Mm-hmm. So why breast cancer? And why, oncology specializes in cancer, but your area is especially breast cancer.
Yes, and that was not obvious from the start. During my internship, which I did in Alingsås Lasaret, here close to Gothenburg, I was one day with my counselor, who was a surgeon, Jonas Petersson, who was performing surgery on patients with cancer. And when I attended him during surgery in the theater, when he opened the abdomen and I just watched those tumors or those cancers in the body of the patient, I realized that I was really fascinated by the disease itself, from how it occurs by mutation and then how it manifests in the body, mm-hmm. and then how it's possible to to try to treat it. So it was when I saw it with my own eyes that I really became interested in oncology or in cancer, but I was never interested in becoming a surgeon. So I realized I would turn to oncology instead. And then during med school, one of my best friends actually died from cancer. And I'm not too sure how that made me become an oncologist myself, but nevertheless, I carry this experience with me. Being 25 years old, my friend got the disease and then died from it quite rapidly. So I think it's this combination of, again, just what made me go to med school, pathophysiology and what happens to people when they are suffering from cancer. And then in Sweden, you train, when you train as an oncologist, it's quite different from other countries. We train as both medical oncologists, that is that we learn how to prescribe the systemic treatments that you talked about in the beginning, the chemotherapies, immunotherapy, the targeted treatments, and so on. And then we also do training in radiation, In other countries, it's more common that you become either a medical oncologist or a radiation oncologist, but we in Sweden become clinical oncologists, and that we get training in both those disciplines, which I also really liked.
So, yeah, go ahead.
Yeah, and then you said why breast cancer?
Yes.
And I was, I think, 3 or 4 years in my training as an oncologist, and I was not really sure if it was the right thing for me. I felt that it was maybe too technical, but then during my 4th year, I started working with breast cancer, and I met with a colleague, a clinical oncologist called Anna-Karin Sikas, and she really had a way of approaching her patients that inspired me. And since then, it's been all about breast cancer, I would say. And I also like that it's a disease that affects the broad population of women. I mean, all ages. And I'm not going to say that I like that a lot of women are suffering, but I do, of course not. But I do like working with breast cancer, since it's how would I say that? I have a lot of colleagues, there are a lot of patients, and there's a lot to learn. I prefer that from smaller diagnosis.
So let's talk about different types of breast cancers. And particularly you mentioned some of the ages and I suppose I'm curious at which age breast cancer is most likely to occur.
In Sweden, the median age is around 66 years, but it does occur in not all ages. But I mean, the younger women below 40, there are only 5% of the affected women who are under 40. But there are some cases, unfortunately. And then we have also women of 80 or 90 years old that can be affected, but 66 years is the most common patient.
So when you think about younger women, I'm thinking about my niece, and I think about my younger sister. And what is hormonal cancer?
Oh yeah, then you come to talk about the different types of breast cancer, and then this is also another thing that I find interesting in working with breast cancer, that there are so many different cancers, and that is, I would say, we know much more today than compared to a few years ago when it comes to tumor biology. So we can divide the breast cancers into different subtypes, and that informs us both about the prognosis, but it also helps us knowing how to treat the cancers. So the most common type, around 80%, is the hormone-dependent breast cancers, or the estrogen receptor sensitive breast cancers. And that's quite tricky to describe in a simple way, but I would say that I used to explain to my patients that the breast tissue itself is programmed to react on estrogen signals. Like when the woman comes into puberty, her breast will grow when she has elevated estrogen levels in her body. And if she conceives and becomes pregnant, then the breast tissue will change during pregnancy. And during lactation, the same. And then when the woman enters menopause, the breasts change again. They become more fatty and less dense. And the same is true when a cancer occurs in the breast, that the cells will most of the time, 80%, continue to respond to hormonal signals. And then that means that we can use that with our treatments by blocking this activation. So the cancer cells, they act like the normal cells in the breast, that they react to estrogen. And then we can use that to slow the cancer down or to kill the cancer cells. I'm not sure if that makes sense to you.
It makes perfect sense, because I have been interested in this hormonal type of cancer that happens in our women.
Most of them, when it comes to breast cancer, are hormonal. Then there are 2 other types, approximately 10% each, or a little bit more for the other ones, that we can characterize in a different way. And that is that one of them is the triple negative breast cancers, and that means simply that they are not they're not estrogen sensitive, and not progesterone, which is another female hormone, and they are not sensitive to, or they do not express HER2, which is a protein that can be expressed on the cancer cells. So they are not hormone dependent.
Okay.
Really.
Wow.
So that means that we cannot treat them with the anti-hormonal treatments. They would not respond to that.
All right. You mentioned that cancer treatments has moved on from a few years ago. What are you talking about when you say a few years ago? Are we talking about 10 years, 20 years, or 5 years ago?
Oh, there are so many different treatments, but I would say the big breakthrough was from the 1970s when we talk about the estrogen dependent cancers, then tamoxifen, which is the most used or the treatment that changed the prognosis the most, I would say. It's a simple tablet that women take once a day, and that blocks the estrogen signal in the cancer cells, and that was introduced in the 1970s. And since then, treatments have been added, chemotherapies, and then in the 19s, another form of anti-hormonal treatment are aromatase inhibitors. And then in the beginning of the 2000s, another targeted therapy was introduced called antibodies against the HER2 receptor, and that is the third subtype of breast cancer that is HER2 positive. And the HER2 positive cancers, they are inherently aggressive, but when we have the targeted therapies with the antibodies, we can really treat them in a sufficient manner. So then that was added. And then I would say every year we have more and more treatments coming. Immunotherapy that you often hear about when you hear about the most recent advancements in cancer treatment has not been such a great success in breast cancer as in other cancer types like malignant melanomas and such. But a few years back, like 5 years maybe, we do have just a triple negative tumors that can respond to immunotherapy in combination with chemotherapy. So, and there are more and more treatments coming all the time. I would say the last 2, 3, 4 years, the antibody conjugates have been the biggest advancements, where we have antibodies and a little chemotherapy molecule attached to it that can deposit the chemotherapy at the site of the cancer so that it can spare the normal cells in the body or the healthy tissues.
Do you think we will erase breast cancer altogether?
Oh, I'm not sure. I don't think so. But there have been great advancements during these decades that I talked about. So prognosis now is much better than it used to be. Today, 9 out of 10 women who are diagnosed with breast cancer will be alive after 10 years, which is a great number, I'd say. And that is thanks to all the treatments that I mentioned, but also to early detection.
Now, when you're talking about 9 out of 10 women survive breast cancer, you are referring to here in Sweden?
Yes, that's correct.
Right. Okay. And do we have any numbers on how many women actually die from breast cancer here in Sweden?
Yeah, we have around 1,300 to 1,400 women dying from breast cancer in Sweden annually.
And is that because there was nothing could be done for them?
I would say that most of them, now when you ask me about different breast cancers, I talked about the tumor biology subtypes, but apart from that, we also stage breast cancer like we do with all cancers, where if the cancer is located in the breast or the local regional area, which is mostly referred to as the lymph nodes in the axilla, then the breast cancer is curable. But once we have distant metastasis in other organs like the bone, liver, lungs, or the brain, then the cancer is incurable. So these women dying from breast cancer, I reckon most of them have metastatic breast cancer or stage 4 breast cancers. And most commonly they are under treatments, systemic treatments for some time, why they have their from the point that they have their diagnosis of metastatic disease until they die. So I would say that much have been done to most of them to minimize their cancer-related symptoms and to try to prolong life as much as possible. But eventually, the disease is incurable, and then you can die from it if you don't die from other things.
So when you talk about the cancer has metastasized, is that the correct word? Right.
Yes, that's correct. Yes.
What would there be? Would it be because the cancer had been discovered, and why would not the cancer had been discovered? It is something that some women just experience. I mean, there's nothing, they can't diagnose it in themselves, and the mammography cannot detect that sort of cancer. Is that?
Oh, I get your question. And then I would say that we have kind of two different scenarios. The most common scenario is that a woman is detected with an early breast cancer, as we say, a curative breast cancer, by either by mammograms, screening mammograms that she attends, or that she will experience a lump in her breast, and then the diagnosis will be found. And then she has curative treatment with surgery, of course, is the most important thing to cure a woman from breast cancer. And then to minimize the risk of metastasis in the future, we can add treatments such as chemotherapy, immunotherapy, and anti-hormonal treatments, as well as radiation, which is the things that I do work with them, to prevent a relapse in the future. But from all the women who have a curative treatment, some of them will relapse with a distant metastasis later, and that is usually a few years later.
Right. Now, there is go ahead.
And then I would just say the other scenario is that the patient is presenting with metastasis from the beginning, and that is called de novo metastatic breast cancer. And that is that the tumor in the breast and the distant metastasis are diagnosed at the same time. And here there are some studies on why does this happen? Of course, if you talk about patients in other settings, not in Sweden, but in other countries where they have less access to early diagnostics, then that's more common with the de novo metastatic breast cancers. But also in societies where we have screening programs and where women do attend, there are still some women with this de novo metastatic disease where metastases are present from the start. And many oncologists do believe that it's another entity. Compared to the ones who have a primary breast cancer and then have a relapse later on. And that's I guess it's all about how metastases occur.
Yeah.
How do cancer cells spread from the breast to the distant organs? And why do the cells start to grow, for example, in the skeleton, which is a common site of metastasis for breast cancer?
Okay,
and we don't know everything yet. But
right. I was just going to
say
now
it starts to be complicated.
Yes. I was going to say, well, do you know how?
Well, there's a lot of research into that, but we do know that breast cancer is a systemic disease, and that's why it's so important to combine the curative surgery with the systemic treatments to try to kill all the remaining or dormant cancer cells that are present in the body. So that's when I guess we will try to, or we will move to the patients who decide to not to take the evidence-based medicine and instead go to alternative medicine, which I think is a risky business.
Now, what happens when? I mean, I know there are cases that I know of one where when a person has been found a lump, and then it was sort of kind of discovered that, in surgery, it was basically discovered that, yes, there is something, but it's not dangerous. And then later, the patient still insists that there is something wrong with it. How can something like that happen?
Oh, you mean that if the patient has surgery and the pathology report says that this is not breast cancer, and then breast cancer will occur anyhow. Did I understand correctly?
Yes, and the original lump that the person found was actually breast cancer, but for some reason it wasn't discovered, or
Really?
And I'm just curious.
Yes, I'm not. I'm not sure. I mean, I'm not informed in this specific case that you talk about, but in general, I would say that. I mean, real good breast cancer diagnostics really rely on good pathologists.
Right.
After the patient, if there's a lump, we have. We take a biopsy, and that biopsy is analyzed by the pathologists to say if it's cancer or not, to guide how we would treat the lump. And then if it looks cancerous, or there's a risk that there's malignancy, the surgeons will remove a bigger part, or the full tumor, and then that tumor is sent to a pathology lab again for new analysis, and then there are many analysis being done by the pathologists. And I think that we, as the colleagues of the pathologist as well as the patients, we do believe that is kind of facit, or the correct answer that the pathology is given. But my colleague pathologists all the time remind me that our examination is a clinical judgment, just as any other doctor. It's not the full truth. I'm not sure if this is informative in the case you're talking about, but perhaps. And the same goes for radiologists, that we do believe that they have the clear answer, but it's a medical judgment.
I'm just thinking about mammograph. How effective is it to find the cancers in breast cancer? How effective are they? Is this machine?
So radiology is not my area of expertise, but I do work close with a breast radiologist. So I've seen cases. I mean, and you say that the machine finds the cancer. It's rather the human who is interpreted, looking at the images and trying to find the cancer.
Yes, that makes sense.
Here we have, and here we have AI coming in.
Oh.
For us today, there are always two radiologists watching the mammograms, and there are some studies indicating that one radiologist plus AI will be sufficient enough, or good enough, or maybe better even than two radiologists. So it's all about interpretations.
Yeah. Okay.
But in general, I would say that mammography is a really good tool to find breast cancer, and then you need to also remember that it differs depending if it's a screening mammogram or if it's actually the investigation of a lump that the woman can feel.
Right.
That's two different things.
Right. Now there seems to be quite a lot of people involved, and so I understand there is a team of health professionals who are involved in the treatment of breast cancer. Can you just briefly describe who are these professionals and what are their roles? I am fascinated. I'm so glad to hear AI is involved. It kind of takes the pressure off the human.
Yeah, yes, maybe. Still there are, AI is programmed by humans, so behind all these algorithms we have humans in the beginning, I think. But AI can really help reducing the workload. I would say. But so, I can describe it from the patient's perspective, from the start of a breast cancer diagnosis. And at first, the patient will attend a mammography department, where she will meet specialized nurses, and then doctors will perform ultrasound and look at the mammograms and do the biopsies. So they are radiologists. And then, as I talked about a little bit earlier, the tissue will go to pathology lab, where a lot of laboratory work is performed, and before the pathologist can look at the tumor under the microscope and see if it's a tumor, a cancerous tumor or not. And then after that, the patient will go to the surgical department and meet with specialized nurses and surgeons who will inform them about their diagnosis and suggest the treatment plan, which is most commonly with upfront surgery. And after that, the tissue will again go to pathology lab, and then we will have a multidisciplinary conference where all these disciplines are present. And then the patient will move most commonly to oncology, where we talk to them about radiation and systemic treatments. And then in the cases where the patient is not cured, we have the palliative care specialists, which will take care of them in near end of life. And then all along these treatment or disease pathway, they will also be supported by physiotherapists and counselors, and I think a very important person is the cancer specialized nurses who try to help the patient to hold all of this together, because as you can hear, it's a tricky road, or they do go to different clinics to get what they need.
Sounds so confusing.
Yes, it's a bit confusing. At the Sahlgrenska University Hospital, we have a breast center since 2019, where we try to be more clear to the patient about who we are and what clinics they will attend, and also the personnel have regular meetings to try to inform each other about the different parts to make it more understandable. And then we have another clinic actually, which is not maybe directly connected to the cancer, but that is the cancer genetics department, because in some cases there are mutations that will increase the risk for women to have breast cancer, and then we can find out and help them so in various ways.
So there is still a genetic, so depending on your genes, you may be subject for breast cancer.
Yes, there are a few genes. The most well-known are the BRCA1 and 2 mutations, and we all have the genes, but the persons who have an increased risk, they have mutations in those genes, making them more susceptible to develop breast cancer. And then we can help them. There are some, we talked about treatments, and there are some targeted treatments that can be used and functions only in the ones with the mutations.
Now, I know you completed your doctoral study in 2025, and you invested...
No, in 2026 actually. Now in January.
Oh, okay. My apologies. Yes. I'm referring I'm referring to the university website. But you investigated the role of something called metronomic treatment chemotherapy. What was that about?
Oh, yes. That is a treatment that was described in the beginning of the 2000 by a researcher who initially did studies on mice with cancer, where he gave them, I mean, as you probably know, chemotherapy do have side effects.
I don't know, because I haven't ever experienced. No, maybe I should come and say, listen, let me get a hit of that and see what it's like. No, I'm joking.
I hope not. I hope not. I hope not. No, but you know, and the patients loses their hair. There's nausea as a side effect, and then the immune system can be compromised, and then of course there is because chemotherapy is not as targeted as other treatments, so apart from the cancer cells, also healthy cells will be affected, and the patient will be tired. We call it fatigue. So there are a lot of side effects, but if the goal is to cure the patient, then the chemotherapy will go on for a limited period of time, like 4 or 5 months or something like that, and then we can manage and we can help the patient to go through it. But in cases when the cancer is incurable, like I said in the beginning, the goal of treatment is to prolong the patient's life, and minimize cancer symptoms, which can be pain from bone metastasis, or nausea from liver metastasis, or difficulties breathing if the metastases are located in the lungs. And then, of course, the treatment side effects must not exceed the benefits. As you can understand, when life is limited, that it's limited for everybody. But if you have a disease that will shorten your life and you don't have much time left, then of course life should be as good as possible, as long as possible. And then this metronomic treatment schedule was proposed to be more tolerable by patients. And the meaning is that instead of giving higher doses at the maximum tolerated dose at intervals of 1 week or 3 weeks, then the metronomic schedule is providing the patients with low doses of chemotherapy daily,
Right.
most oftenly by chemotherapy tablets, to minimize the side effects and try to get as effective treatment as possible anyway. So that has been suggested many years, and I was investigating it in metastatic breast cancer.
Wow. And what was your findings? Did you have findings that it worked, or in some patients and in others maybe not so positive?
Yeah. And then when you say to know if it works, then we must know what does work mean. I mean,
Yep.
I found that it could be effective and control the cancer for approximately around 9 months, which is comparable to other treatments. But I didn't, in my studies, I didn't compare it to other treatments. So
Okay.
it's a bit hard to say if it worked in that sense. But then I also performed a qualitative interview study with 10 women who had experienced this treatment. And they expressed, and most of them had experience from other treatments, such as intravenous chemotherapy at higher doses. And they expressed that they really appreciated the treatments, since it enabled them to try to live a life as close to normal as possible in their situation. So that's another way of working, I think.
Now, in your role as an oncologist, you had some challenges that you experienced in meeting with women who had been diagnosed with breast cancer. What were some of your challenges?
Well, I mean, to have a cancer diagnosis will always be an existential crisis. So that's, of course, is a challenge to try to meet these women and to give them what they need in terms of both information and also, I don't know, somehow providing them with security and make them feel taken care of. And that's a challenge in the busy clinic. It's a high workload, I would say, for all the staff in oncology care, both doctors and nurses.
And probably quite stressful, emotionally stressful.
Yes, it is, and especially when time is constrained. Then, I mean, we try to, if you would say, produce the care that they need, but the time for more existential talks, and also for us in the team to have time to contemplate on what we experience and what we meet, that's the time that will be cut when clinic is busy. And I mean, it's a good thing, as we have talked about. There have been so many advancements during the last decade. So of course we need to be more skilled healthcare providers to meet up with the needs and all the advancements that we have seen. And I think, oncology has been a really growing specialty, and it's hard for the community to provide personnel to do the work. So that is a challenge, yes.
Yes. Now, what are your thoughts about alternative treatments for breast cancer in particular?
So I'm concerned about it, I would say, because, as I said, to have a cancer diagnosis is a real big crisis. And most women or patients really wonder, why did I have this cancer? What happened? Why did it occur? And they try to understand it, and they also want agency. I mean, they want to know, what can I do to become healthy or to stay healthy? And then there's a risk, I think, when these alternative medicine practitioners enters the field and give simplified answers to these questions to people who are in a vulnerable situation. So that concerns me.
So I'm thinking about why women, or some women, refuse cancer treatment backed by science and instead choose these alternative treatments. And you mentioned something that, there is a lack of time to talk about whether if I was to come, I would be, yes, give me the facts. Yeah, this is and this, and you can kind of draw a picture of what happens in the body. But then there are those questions such as a fear of dying, how to manage the stress. Now, you mentioned there are the nurses, but this is also something that, because when you mentioned that the treatment that are given to patients actually affect, whether it's hair loss or, all kind of pain and nausea. I mean, yes, these are the facts of their treatment, but there must be some, and that's when I think, well, there are people who would turn to alternative treatments because the actually underlying fear is of dying.
Yeah, I think there are many layers to these questions that you arise. Both, but I mean, many of the alternative treatments are kind of the one who are selling them, and I say selling them because that's another concern, that some people really earn a lot of money on these women. But those who are selling them claim that they are not do not have as many side effects as the traditional treatments or the evidence-based treatments that we prescribe. So that's one part of it. But I think it's a more superficial part of it. I think those women, and it's not common that women with breast cancer say no to the evidence-based treatments 100%. It's more common that they combine. But those who say no to the evidence-based treatments, my experience is that they have another view on what cancer is, why it occurs. They have ideas such as that the body has an imbalance that needs to be corrected or something like that. They have alternative explanations of the disease, I would say. The ones that combine, they are more easy to reach, I would say. But those who deny our treatments completely, that's another category.
What do you say to those women who refuses cancer treatment offered by the breast center at Sahlgrenska University Hospital?
I mean, now when you hear me talking, I'm quite direct that I don't believe in it and that I think it's problematic, and I say that to those women as well. But I also try to be open to their point of view, to try to listen to their arguments, and try to be as non-judgmental as possible. And I always say to them that the door to us, to Sahlgrenska, is always open. And if they change their minds, they're always welcome back. And that's also a difference between us and the alternative. I don't know what to call them, the alternative people. That we are always there for the patient, even when things do not go as they have planned.
Wow.
But in recent times, I've been working with this for breast cancer with I would say, some 10 years. And I used to be more open to the patients before, but I more and more as time goes by, I think that it's also my job to state clearly to them that there's no evidence behind those treatments, and that I recommend them to abstain from them.
So you you don't think there will be a magic pill that will see the end of breast cancer?
No, I don't think so. Not completely, but we will continue to improve.
Yeah, but less painful treatments that may be offered than today, like you mentioned about the study that you were doing for your PhD, where the chemo. I find that's fascinating that you can get a tablet, and say what anyone says about AI. I think it's great that there is the support of artificial intelligence, how it's used properly to alleviate some of those fears. That's why. I mean, I don't know why do we believe in alternative? I mean, I believe I know my body well, but hey, I have no idea about the different organs or, the internal, because it's never been my thing, if you like. I like to, and that's where I'm just. So I believe in that. It's good that there is artificial intelligence, and absolutely people like yourself who speaks the truth.
Yeah, and then I think we need to be, how would I say, be humble, that we don't know the full truth, as you say, about the body or about cancer. We don't know everything yet, or we will perhaps never know everything. But we need to act upon what we know at the moment, of what is right at the moment. And I think this might be also a difference between evidence-based medicine and the alternative medicine. That in evidence-based medicine, we put up a hypothesis, and then we try to prove them right or wrong, and act upon that. And we don't claim to know everything or to be able to explain everything. And I think that might be a difficult thing if you're a patient who have breast cancer. People have different capacities to deal with uncertainty. The most or a very common question to me is, why did I get breast cancer? And the truth is that we can't really answer it. We know that there has been a mutation in a cell that the body couldn't control, but we are not sure of why that happened. It's bad luck. It's not something that we can explain. And I think people want explanations when they are in a vulnerable state.
Yes, have I been good or have I been bad? And I've been yes. The other
Did I do anything wrong?
Yes.
And I think this is another problem with some of the alternative medicine, that they put a lot of guilt on the patient. If you would eat like this, if you would practice more, if you would lose weight, if you would not eat sugar, if you would do this and that, if you would not eat this or that food, or if you would not be so stressed or whatever, then it wouldn't have happened to you. And I think that's not fair to patients to put so much guilt on them, with explanations that are not proven to be correct.
And the sad thing,
you said you asked about the future in breast cancer, and I started by outlining all the treatments that have been added through the decades to improve the prognosis. But during the last decade, I would say that in breast cancer there has been an era of de-escalation of treatments, because we know that we do better with the treatment, but there's also a risk of over-treatment for the patient group as a whole. And what has been done in the last decade is that we are more and more individualizing the treatments. There are some more advanced tests for the tumors to know if the patient will really benefit from chemotherapy or not. And by knowing when we can spare chemotherapy, when the prognosis is good without chemotherapy, we can minimize the side effects by giving the treatment to the person or the patient who really needs it, and spare it for the ones who don't need it.
And that's a positive
so it's not
thing.
Just about adding.
Yeah,
it's a positive thing.
Absolutely.
Because it's not just about adding. It's also about giving the right treatment to the right patient.
I'm just thinking, is there anything you want to add to the conversation that I have not brought up?
No, but just maybe something I want to ask you. I have been thinking lately that cancer, and maybe in general, but breast cancer in particular, has become such a societal interest for many people. And I'm not sure if it symbolizes something, or if many people know somebody or were affected themselves, but somehow it seems to be interesting on the societal level. I'm not sure if you have any thoughts on that, but why that is.
Why there is an interest on breast cancer? I think it should be. I think there should be interest in any issue relating to women, and this is why we need to get the facts out there. We need to have people like yourself, and I'm so grateful that you're responding to these questions. It's a bit like conscious racing. A lot of times women, we didn't talk about women's issues. Well, I'm not, it was only when my sister was...
And then I would just add another aspect of the thing with alternative medicine. I mean, I'm mostly interested in breast cancer and breast cancer treatments, and then I just happened to think a lot about the alternative treatments in relation to that. But then I saw it also at a broader perspective of democracy and I mean the belief of science and what is fake news and who are the people earning money on these desperate patients, or who are the people who are spreading these false ideas uncontrolled, and that's something on a bigger societal level that I think really has increased in the last few years and is a threat to society.
Absolutely. You just said it. This is a women's issue, but it's also a societal issue. And that's what I'm thinking. And you're bringing it up. And I think sometimes, and I'm sure there are specialists, and I think sometimes we underestimate science. And that's why we need to bring science to the front. Instead of trusting these... people with these alternative ideas about how our bodies work. And so that's, and the spreading of fake news is just bizarre. And so
yes, the distrust in the institutions, the universities, and the serious media or the school and educational system really needs to be strengthened. I think it's dangerous on a bigger level when these fake news are being spread and people. Everybody needs to be critical about all the information that they are over flooded with. And then when it comes to cancer, I understand that if you have a cancer, you're in such a vulnerable state that then you're probably prone to, to accept other explanations if it suits your fears, or as you say, fear of dying. Nobody wants to die from cancer, and if somebody comes and say, "I can fix it for you," then of course many people do want to believe that.
Yes. Especially if you're in the situation, like you said, you're vulnerable. Yeah. And that's where the role of common sense and a belief that, look, let's have a good look at what actually can be done about this. Because you know what I'm worried about too, that while we talk about numbers, that so many have got breast cancer, but do we really know the actual number? Are there perhaps women who hide the fact that they are suffering from breast cancer, and they don't, they don't. I don't know.
No.
Do you know what I'm trying to say?
Yeah, absolutely. We do see those cases, and that's called patients delay when women or patients present in a very advanced stage where they have been hiding their tumors, or maybe not hiding. Some of them also do not understand what's going on in the breast, and then sometimes they present in a very late stage of the disease.
And it's precisely when they present at a very late stage of the disease that I am wondering, especially here in Sweden, where does that go back to? Has that got to do with our education? How can we improve on that? These are issues. And so for me, breast cancer, and in fact any cancer, and I do not minimize prostate cancer, men's prostate cancers. I think there is also the hidden factor, there are men who are suffering from prostate cancer. They keep it hidden.
Yeah, that's true.
So we human beings are a bit strange.
Yeah, we are interesting. Interesting.
You say interesting, I call us strange.
Yeah.
So tell
me.
And
another thing, I would just add one last thing, and that is, we talked about the women who decline evidence-based treatments completely, but then it's more common with women combining evidence-based treatments with complementary or alternative treatments. And that has become an increasing concern for us in the healthcare system, that women or patients are asking us questions about those treatments, which is a good thing, that they're open and want to discuss them with us. But I'm a bit concerned that some parts of the healthcare sectors believe that we need to inform ourselves on those treatments more and more. And I think that's a dangerous path to go as well, because we need to be clear that there is evidence-based treatments and non-evidence-based treatments. And we, as you said, the time is short, and women have a lot of needs that they want to discuss with us, and we cannot occupy ourselves by learning or discussing a lot of those alternative treatments with patients, but because it's not fair to the patient group as a whole, and it's not our job to do. I mean, somebody who claims that this works against cancer, they need to show it proven.
Absolutely.
If you understand what I'm trying to say here.
Evidence-based. But you see, Caroline, that is why the conversation with you today is so appreciated.
Oh, thank you, Lisa. It was really nice of you to let me speak about this issue.
Oh, I think it's absolutely necessary, and I'm just very, very happy that you have, and you've been so clear and so, and as I said, even if I don't understand all the terms, I'm curious, because you kind of give a sense of, oh, thank God we have someone who makes sense.
Oh.
You know what I mean? And just one more final question. What would be your message to women and their partners who might be afraid of chemo?
I would say to them that it's very how would I say it? I would validate their feelings, saying that yes, it's good to be afraid of chemo, because that is a really strong systemic treatment. So it's correct to be afraid of it, or I don't correct. If you're afraid, you're afraid. It's nothing that I can say anything against. But I'm also a bit afraid of chemo as an oncologist, and that is that's why I need to be very responsible when I prescribe it. I need to think, what does this patient in front of me benefit from chemo, from the cancer point of view? And then I also need to think about what are the comorbidities? Does this patient have other medical conditions that will make it more dangerous? How old is the woman? And is it reasonable to do it? So chemotherapy really needs to be prescribed with responsibility, and that is from the part of the oncologist, but also from the side of the patient. That the patient need to be informed about the risks and know what she should look after, and that she must contact us if she experiences any of these side effects. And if that's performed in a secure way, then it's not dangerous. I'm not so scared of it. But it's really an important thing to sit down together and talk through.
And also, I think the survival rate of coming out of is something like going through all these medical procedures is actually the survival rate. So if I follow that, what are my chances? And I think that message should be the first one I would listen to.
Oh yes, of course. So it's reasonable to be afraid of chemotherapy, but it's also reasonable to be afraid about what will happen if I don't do it.
Exactly. So the survival rate. So today's treatment, if it's early, breast cancer is diagnosed early, the survival rate is 9 out of 10, or is it?
Yeah.
It is.
Yeah. Oh no, yes. We measure it at 5 years interval, 10 years interval, and then it exceeds beyond that. But the cutoff points is usually 5 and 10 year survival rates.
Right.
So in Sweden, 9 out of 10 survive at 10 years.
And then they go on to surviving after they pass the danger. Oh, that is such positive news. That is such positive news. Caroline, thank you so much for taking the time out from your busy schedule. And this has been a total privilege. Thank
you, Lisa. And thanks for your curious questions. It was wonderful.
Okay. And listen, I hope you will have a fabulous midsummer.
Oh, thanks. The same to you.
Yes. What are you doing? Can I ask?
Not much.
But that's the best answer.
Eating some herring and strawberries, I think.
Oh.
And hoping for the rain to disappear.
Yes, but we needed the rain, and the Swedish strawberries right now are delicious.
That's true.
I've been living on strawberries. Thank you so much, Caroline.
Thanks, and have a nice day.
And you have been listening to the podcast Sånt är livet i Sverige, or in English, That's Life here in Sweden, with me, Lisa Åsimäki. Till next time, take care of yourself and each other. Bye for now.